So next we move on to never miss intraocular foreign body, how to assess. And this talk is by Dr. Sapna Mohan, who has his MBBS from Trichu, Jubilee Mission Hospital, and um, medical retina specialty from Comtrust Eye Hospital. And at present, she is faculty in the Malabar Medical College, Calicut. Dr. Sapna.
Good morning, all. Today I'm going to talk about how to look for an intraocular foreign body. So intraocular foreign body is typically defined as an intraocularly retained unintentional projectiles that require urgent diagnosis and treatment. It is seen in up to 16 to 41% of all open globe injuries, and the commonest cause being work-related trauma and typically affects young males. So it's a true medical emergency. Failure of diagnosis and delay management can often result in complications like hyphema, corneal scar, traumatic cataract or subluxation, retina detachment, retina dialysis, endophthalmitis, and metallosis like cirrhosis or chalcosis. So, describing about the types of intraocular foreign body, we have inert substances like glass, plastic, stone. We have metals like copper or iron. We have organic materials like vegetative matter, cilia, or even caterpillar hair. The most common foreign bodies being metallic and magnetic objects. Coming to pathophysiology, the final resting place of an intraocular foreign body and the total damage caused by a foreign body depends upon multiple factors like size, shape, composition, and momentum. Larger the size and more irregular the shape, more the damage. Composition, vegetative matter are known to cause infections like endophthalmitis, and metals are known to cause inflammation like cirrhosis, chalcosis, etc. Greater the momentum, deeper the penetration, more the damage. It is widely known that a foreign body entering through the sclera are known to cause more damage than those entering through the cornea. Coming to history taking, it is a most crucial step because most of the children and bystanders are more susceptible to being unaware of the injury and they may present later. But many people present early if they feel symptoms like decreased vision, foreign body sensation, flashes or floaters. So special attention during history taking should be given to the mechanism of injury, whether it is drilling, hammering, welding, blast injury, whether it is machine cutting of organic matter like wood. This will give us an idea about the composition of the foreign body. In evaluation, it is important to consider that all open globe injuries to have an intraocular foreign body until proven otherwise. We should maintain a high index of suspicion. Most medical legal cases against ophthalmologists are because they miss an intraocular foreign body following a trauma. So in most of these cases, the patients will be innocent bystanders. So it is very important to take a detailed history to identify the intraocular foreign body. Coming to clinical examination, we should record the visual acuity. Special attention should be given to the pupillary shape, presence of RAPD and isochoria. We should look the area around the wound for any localized injuries, lacerations, canalicular injury or remnants of foreign body. If ruptured globe is suspected, we should not do an applanation tonometry until the primary wound is closed, and we should identify the entry point if it is in the cornea or sclera, and then we have to chart a trajectory path. In the sclera, the entry site will be typically masked by a conjunctival ingestion, hemorrhage or chemosis, with or without a conjunctival laceration. There can be a pigment over the entry site which indicates uveal prolapse. In the cornea, the entry site will show a description of the smooth, transparent surface with corneal edema around the site. There may or may not be positive serial test. In the iris, we can see transillumination, heterochromia, hole at the site of foreign body entry. In the lens, we can see focal opacity at the lodgement, or we can see subluxation of phacodonosis. Iris is ideally examined before dilatation and lens is examined after the dilatation. Fundus again should be detailedly examined with an indirect after dilatation to directly visualize the intraocular foreign body in the posterior segment. Gonioscopy and scleral depression should be ideally delayed until we close the primary wound. Coming to localization, now X-ray, it is less sensitive than the CT, but it is done as a part of screening. It is capable of picking up radio-opaque foreign bodies, but it is not capable of picking radiolucent ones. The standard for X-ray series for foreign body include anterior posterior view, lateral view, Waters view, and Calvel's view. So that helps in detection of foreign body. But for localization, whether it is in the anterior segment or posterior segment, we need metal markers like limbal rings or contact lenses with metals. Then Berman, Roper, Hall, Bronson, Turner are various electroacoustic metal locators which are used to pick up magnetic foreign bodies. CT scan, now the gold standard for detection and localization of intraocular foreign body. We can use axial and coronal view slices which are highly sensitive, less than 1.5 millimeter cuts, no manipulation, good cooperation from the patient, even done with open globes. It is not beneficial in detecting smaller foreign bodies and radiolucent foreign bodies. Ultrasound B scan, again, it can detect both radio-opaque and radiolucent foreign bodies. It can be done after the repair of the primary wound. It has got higher resolution, lower cost, and it can produce multiple images at a very short period of time. So what do you actually see in a B scan? We can see a hyperechoic lesion that even persists in a low gain. The corresponding A scan overlay will typically give you a 100% tall spike, and there will be acoustic shadowing, and we can also pick up other concurrent pathologies in the retina like endophthalmitis, retinal detachment, vitreous hemorrhage, etc. So MRI, it is not routinely done in case of an intraocular foreign body, especially not done if you are suspecting a metallic foreign body because it can cause potential more damage, but it is more effective in localizing non-metallic radiolucent foreign bodies like wood and plastic. Now coming to the prognostic factors, initial visual acuity, if it is better, better prognosis. Size and location, larger the size of the foreign body and posterior location are considered to be poor prognostic factors. Size, larger the entry wound, and if the foreign body is entering through the sclera, this is again a poor prognostic factor. Lens injury, if it is present, it is a poor prognostic factor. Younger the age group, worse the prognosis. Presence of RAPD, presence of intraocular hemorrhages like hyphema or vitreous hemorrhage, retinal detachment, endophthalmitis are all indicators of poor prognosis. And certain studies have shown that posterior chamber intraocular foreign body, if not removed before 24 hours, can significantly affect as a poor prognostic factor. Coming to management, we have to protect the globe with a shield, not a patch. Area around the wound should be cleaned of any remnants of foreign bodies. A broad spectrum antibiotic have to be given. Vegetative matter foreign body, if suspected, it should be removed immediately, ideally within 24 hours. High speed small metallic foreign bodies, they are usually auto-sterilizing, so we can wait a little longer. The most important step is the closure of an entry wound. So if it is an anterior chamber intraocular foreign body we are suspecting without any lens involvement, the pupil should not be ideally dilated or constricted to avoid further movement of the foreign body. Any wound, if not self-sealing, should be sutured. Reformation and maintenance of the anterior chamber should be of utmost importance. And the intraocular foreign body should not be removed through the entry wound. An extra shelved incision, almost the size of the intraocular foreign body, should be created in the clear cornea or sclera for its removal. If there is lens involvement in the form of phacodonosis, subluxation or opacity, we can do a lensectomy done with phaco or SICS. Concurrent IOL insertion is not ideally done because of the risk of severe post-operative inflammation, but anterior capsule is retained for future IOL insertion. In cases of posterior chamber intraocular foreign body, we do a 3-port vitrectomy. The sclerotomy site should be ideally away from the entry site of the foreign body. The main goal is to remove the foreign body after removing the adhesions. Before removing the foreign body from the retina, we have to apply lasers around in the surrounding retina for preventing retinal detachment and also to prevent bleeding. Peripheral evaluation of retina and removal of adhesions is also important. In case of an encapsulated foreign body, after dissection of the foreign body, it should be removed using a magnet or forceps. And if the intraocular foreign body is larger than the probe or the sclerotomy site, we have to circumferentially enlarge the sclerotomy. In case of a very large intraocular foreign body, then it is best managed through a limbal incision after lensectomy. So we have to turn the infusion line off to prevent any iris prolapse. Then the posterior chamber intraocular foreign body is brought into the anterior chamber through the pupil, and then a second forceps is introduced through the limbal incision, and it is brought out of the anterior chamber, and the limbal incision is closed. So in most of the trauma cases which are intervened after 24 hours, there is a high risk of endophthalmitis. So we have to give a prophylaxis with intravitreal vancomycin and ceftazidime, the most common organism being Bacillus cereus. So in those patients who are allergic to penicillin, we can even give intravitreal amikacin in the place of ceftazidime. Thank you.